As you can see, I'm Esther Abels. I'm the Chief Clinical Regulatory Officer. We all know that efficient digitization and analysis of images has advanced by improving the tracking and organization of information, which could lead to efficiency of the pathology labs. The introduction of AI-based tools are expected to provide clear performance benefits and parameters, such as turnaround time, data quality, and more comprehensive patient reports. We also realized that the costs of implementing digital workflows could be high. Additionally, current reimbursements for pathology services is insufficient to cover the cost of technology acquisition. Fortunately, the reimbursement in the US is shifting more and more to value-based care models, which brings us an opportunity to use innovation to drive new reimbursement paths. There are three key value propositions in digital pathology that each individually or collectively offer distinct value to the healthcare system, justifying reimbursement. One is the technologies to improve pre-analytics. 2, to perform new or different analysis. 3, technologies to improve clinical care. Let me present each category in the next 3 slides. The first category is advancements to improve the pre-analytics workflow. That is sample process, accuracy and efficiency in comparison to existing approaches. It allows you to streamline workflows. Currently, there is a challenge of infrastructure costs when you first develop and purchase the technology in that point in time. So we have to show that it leads to greater efficiency and thus value over time. Examples are improving staining quality or case prioritization. The second category is that it can perform analysis that were previously impossible with traditional pathology. An example of such an application would be an AI-driven software algorithm to provide unique patient risk stratification information, inform possible treatment ideas which potentially could not be identified with the human eye. For these offerings, rather than relying on a series of existing professional or technology codes, like is being done right now, one could leverage the new proprietary laboratory analysis coding systems. These PLA allows for creations of codes specific to identify a particular offering based on value and a clinical benefit, or linking it to the complexity of diagnosing a particular disease. Finally, the third category is emerging and could support improvements in clinical care at the health system or even the population level. These tools could require for novel reimbursements requiring a shift from viewing digital pathology as solely a reduction in costs to a source of value, because it could improve precision and accuracy. We should start to address this category in a holistic view, instead of looking at a single stain or a slide. We should look at it from the perspective it could provide equivalence or even better prediction, as well as outcomes with more standardization, resulting in reduction of retesting or confirmatory testing and less effort on a case-by-case basis. And similar as to in the regulatory trajectory, there are many stakeholders in the reimbursement trajectory, and the value of digital pathology may be different to various stakeholders. Also here, we have to work as a collective to tell a cohesive value story to drive reimbursement paths. Stakeholders are payers, hospitals, labs, pathologists, clinicians, and patients. And value of digital pathology will impact each one of them differently. Therefore, just like in regulations, it's important we understand each other and consider how digital pathology may influence decision-making for each stakeholder and how those different values may build to something greater before pursuing evidence development. And that is why we at Visiopharm have now set up a collaborative approach virtual workshop with limited seats available, but you can sign up via our website at visiopharm.com. Looking at it per stakeholder, payers. Generally, the evidence of reduced costs and improved clinical outcomes are highly valued in payer decision-making. However, what is most important is to demonstrate that these novel technologies have clinical utility. For hospital administration labs, the annual operating costs for labs are highly affected by the purchase of new instruments, their implementation, validation, maintenance, downtime, effectiveness. Decisions to purchase and implement new equipment in the lab are highly dependent on the return on investment. The potential for a reimbursement of a technical component can be highly influential in the decision-making process. For the pathologist, numerous benefits of digital pathology to pathologists have been documented in the many studies that have correlated its use with greater accuracy and precision in pathology results. And as Dirk presented, 30% of the cases can be misdiagnosed due to staining. So we should focus that the aim of digitization and especially computational pathology is to maximize the impact of the pathologist, utilizing the standardization in pre-analytics, allowing the pathologist to focus on the more complicated cases. For the clinicians, with harmonized and standardized pathology reports, clinician understanding of pathology reports and subsequent decision-making could be improved. For the patients, uptake of digital pathology has the potential to reduce turnaround time and improve the accuracy of pathology reports. In addition, pathology specialties can be accessed more efficiently. All these are important for patients. It could reduce anxiety as well as earlier access to the right treatment. This slide shows that we should align the stakeholders to optimize the value proposition early in time. Once we have that, we can take the next steps, which are as follows. We can define key endpoints and outcomes relevant to demonstration of the value add of the technology. Evaluate improvement in response to therapy or delay in disease progression are very useful. For example, we can show where we truly can perform better. Another one is create a foundational understanding of the limitations of the current care paradigm, so that the unique benefits of the technology can be highlighted. For example, we could use COVID for remote sign-out, that it can provide the clinician with the information needed to initiate an appropriate course of therapy sooner and thus provide a better outcome for the patient. Another one is utilizing new reimbursement codes, leveraging the new PLA coding system, which allows for creation of codes specific to the particular offerings. And for a long-term effort, for example, we can also collect evidence to support reimbursement in a value-based system, requiring us to move from viewing digital pathology as a reduction in cost to a source of value. Herewith, I would like to restate that a better understanding of reimbursement and the different stakeholders will provide information to drive a payer strategy and drive this field forward. I would like to conclude and thank you for your time and attention today.